Hi, I'm Conrad Fisher, and welcome back to our next case. The next case is macrocytic anemia. What we'll be doing is we'll be trying to extract every question we can out of this particular disease subject. We always stay with our usual basic format. What is the most likely diagnosis? What is the best initial test? What is the most accurate test? What is the best initial therapy? Which of the following physical findings most likely to be associated with this patient? What is the most likely diagnosis? What is the best initial test? What is the most accurate test? What is the best initial therapy? Which of the following physical findings is most likely to be associated with this patient? Now, let's look at our first slide here in macrocytic anemia, and we have a 68-year-old woman who presents to the office, fatigue, slowly, several months. Shortness of breath, past several weeks, and her pulse a little high at 107, and she's got some decreased sensation on her feet. So we have an anemia. Normal hematocrit for a woman is about 38 to 42. For a man, a little bit higher if the man is not menstruating. Now, hematocrit is a little low, and the MCV here is high. So that's why it is a macrocytic anemia. So the bottom line of this case, we have a macrocytic anemia with a little bit of decreased sensation at the bottom of those feet. Next slide, excuse me. Which of the following is the most likely diagnosis? Now, what do we see here? Folate deficiency. Could it be folate? Well, folate it could be in the sense that folate is a macrocytic anemia. Folate could be. G6PD deficiency. Does G6PD give macrocytosis? Well, in the sense that reticulocytes are slightly large, and all hemolytic anemias have a slightly high MCV. Next one, hemolysis. Well, it has a slightly high MCV, but hemolysis does not give you the MCV that is often very high. The other thing is that hemolysis is not going to be happening over a slow time. There's only one form of hemolysis that happens all the time, and that is sickle cell. So only sickle cell anemia is going to happen over chronically. G6PD, well, the other thing is this. Does it say that she's a
This file has been copied from www.feedyourbrain.com.
Fava beans as a main course and dapsone for dessert? No. Also, what's the most common cause of hemolysis in G6PD? What is the most common cause of acute hemolysis in G6PD? It is infection. You know, with only 1,000 cases a year of malaria in the entire United States, and only 10% of them being VVAX and Ovali, it's very unlikely you're going to be tossing around any Primaquine in your lifetime. Dapsone is a management for pneumocystis prophylaxis in people who can't tolerate Bactrim, trimethoprim sulfa. Well, chances are you're not going to be throwing too much Dapsone around. And I think we're not going to be seeing too much leprosy on the US, the USMLE. Well, the USMLE doesn't have too much leprosy. You're not going to be seeing too much Dapsone. And fava beans, I don't think that you'd know what a fava bean was like. If I throw a fava bean across the room and hit you in the head, doing, what was that? It was a fava bean. Really? I wouldn't even know that. So therefore, looking for a Greek man who has Primaquine as an appetizer, fava beans as a main course, and dapsone for dessert is highly unlikely for you. But infection, everybody has. None of those things are in this case. So there should be going our G6PD. Liver disease, it can be.
This file has been copied from www.feedyourbrain.com.
Why? Because the extra fats of liver disease that are not metabolized, you ready? The fats get sort of put on the side and put on the side. Makes it a little wider, doesn't interfere with function, okay? Function's normal, just a little wider. It's sort of like cellulite for red cells, red cell cellulite. But liver disease also. Now, sideroblastic anemia. What should you be looking for the case for sideroblastic? Most common cause of sideroblastic anemia? Sidero is a $5 word for iron. Sideroblastic anemia is most commonly caused not by lead. I never heard of a mojito with lead. What kind of margaritas do you have here? We have mango, blueberry, pomegranate, and lead. So I don't see any lead margaritas. So the most common cause of sideroblastic anemia is alcohol. Alcoholia, that's it. So sideroblastic. Doesn't say she's alcoholic. Could be sideroblastic. The other thing is this. The alcohol could be causing the decreased sensation in her feet. However, unlike most of our relationships on USMLE, if they want you to know the answer, they have to tell you something. If they want you to know the answer, they have to let you know. So they didn't put anything in there about her being a massive alcoholic, did they? So it's hard to say that she's got decreased sensation on her feet and sideroblastic anemia from alcohol when they didn't tell you anything about alcohol. Oh yeah. Now, that makes this case most likely to be due to B12 deficiency. Macrocytic anemia with neurological problems. Macrocytic anemia with neurological problems, B12. Our next slide. And in this slide, we're going to read the case, which is, interestingly enough, the same case. And this case says, which of the following physical findings is most likely to be found? So we're going to take a look at these pictures. We're going to take a look at these pictures and we're going to see them pop, pop, pop. And we're going to take a look at each of these images. And as we look at these images, bang, image A. We see a woman who's got hypopigmentation in spots around her hands. Image B, bang, we see an abnormality in the ophthalmic distribution, V1 of the trigeminal nerve, a sensory nerve. Image C, bang, we see silvery, scaly lesions on the surface of the skin. Bang, D, we see a lesion that has a pearly, shiny like a pearl, and is a type of skin cancer. Answer E, bang, and we have a thing that looks like a grown cauliflower off the side of the skin. Now answer A, if you see it, looked at the picture, is vitiligo, which means she's hypopigmented spots. Picture B, look at the picture, is ophthalmicus zoster. Is V1 distribution, ready? Right? It's like John Travolta in the Pulp Fiction. I always think of that when I see that. I go, ooh, zoster ophthalmicus. Yes, zoster ophthalmicus. Okay, so is zoster associated with B12 deficiency? And the answer is no. You know why?
This file has been
B12
copied from
does not affect
www.feedyourbrain.com.
So therefore, HIV and being elderly gives zoster, but not B12. C, the answer is psoriasis. Is there an association of B12 with psoriasis? Absolutely not. D is the picture, basal cell carcinoma. Is there an association of B12 deficiency with that form of skin cancer? And the answer is no. B12 and skin cancer do not meet. E is seborrheic keratosis. Now, when you see the word seborrheic in the skin, seborrheic means benign. Seborrheic keratosis is benign skin lesion. If it's your face or Madonna's face, we might take it off. If it's people, it's cosmetic. It has no malignant potential. Looks like something that's growing that's not you don't like, but has no malignant potential. So seborrheic is benign. Seborrheic keratosis, benign. It's like a mutant liver spot in pale people. Seborrheic dermatitis, benign, also known as dandruff. So when you see the word seborrheic, it means nothing. Actinic keratosis, evil, premalignant. Actinic keratosis goes on to squamous cell cancer. Actinic comes from the sun. The Greek god of the sun is Helios, and Helios sends the actyon, the sun ray. And the sun ray causes premalignant skin lesions, like cervical dysplasia of your face. Premalignant, let's get rid of that before it transforms. So the one here that's associated with B12 is vitiligo, image A. So vitiligo, because vitiligo make little antibodies against your melanocytes. Hashimoto's thyroiditis, antibodies against your thyroid. Addison's disease, antibodies against your adrenal. Pernicious anemia, antibodies against your gastric lining, an intrinsic factor. Vitiligo, Hashimoto's, Addison's. Monoclonal gammopathy,
This file has been copied from
unknown significance. Now, monoclonal
www.feedyourbrain.com.
significance is just extra immunologic noise. It means that the body is reacting against something, ghost of something from your past, an imagined injury, thinking that there's an antigen coming in, and you make antibodies against it. What antigen? That one there. Where? That one. Oh. But I don't see the antigen. No, it's there. I'm making antibodies against it. Oh. Well, pneumococcus is coming in. Okay, I'll make antibodies against that. Varicella is coming in. No problem, I'll make antibodies against that. This infection is coming. Okay, I'll make antibodies against that. But that bad guy's still attacking me. What one? I don't know. So what would you call that if somebody was buying spy satellite detection equipment and was under the delusion that they were being attacked by something no one could see? But when it came time to pay their phone bill, their electric bill, their cell phone bill, they still took care of their bills, pay their taxes, obey the law, but they're under the delusion that they're being attacked by something. Well, for the body, here now, for the immune system, we call that monoclonal gammopathy of unknown significance, and it's associated with pernicious anemia, B12. But for the immune system, it's called delusional disorder. Delusional disorder means that you're under the impression you're being attacked by something, and you do things to defend yourself. But you obey the laws, pay your taxes, pay your bills, and take care of activities of daily living. Delusional disorder. So B12 deficiency, pernicious anemia, is a type of delusional disorder for the immune system. You're making antibodies against your melanocytes, Addison's, Hashimoto's. Monoclonal gammopathy of unknown significance, antibodies. So vitiligo, pernicious anemia, Addison's, Hashimoto's, monoclonal gammopathy of unknown significance are extra antibody noise that tends to happen past the age of 60. Ooh, how interesting. Ooh, Dr. Fisher, you're a deep and poetic guy. That's true, I am. Now, next slide. We have a 68-year-old woman, again, slowly fatigued. The difference between this case and the other one is, what's the best initial, says very specifically, what's the best initial diagnostic test? I like a B12 level. I like a bone marrow. Folate level should also be done because you could have both of them occurring together, and you can't tell for sure whether it's folate deficiency or B12 for sure, or both of them together to get a folate level. Schilling's test is never to determine if you have B12 deficiency. Schilling's test is, you have B12 deficiency, now what's it from? You have B12 deficiency, now what's the etiology? You have B12 deficiency, now what's the cause? That's what Schilling's test is. Schilling's test is, you have the disorder, now what's causing it? Schilling's test. But Schilling's test does not diagnose B12 deficiency. The best initial test actually is the peripheral smear. First of all, the B12 level can be falsely normal in 30%. I know you feel robbed, don't you? I do too. What do you mean it can be normal? You're deficient, but it's normal? I've been misled to. I've been lied to. Well, it turns out that transcobalamin, the carrier protein, is an acute phase reactant. Like a white count. Step on my toe, my white count goes up. I have an infection, my white count goes up. I have cancer, my white count goes up. Turns out transcobalamin is like sedimentation rate. Infection, inflammation, cancer, my sed rate goes up. It's like a C-reactive protein. You have a cancer, an infection, inflammation, my C-reactive protein goes up. And so does your transcobalamin, the acute phase reactant, and the carrier protein. White count, sed rate, C-reactive protein, ferritin, and transcobalamin. Again, a white count, a sed rate, a C-reactive protein, a ferritin, and transcobalamin. Oh yeah! And that's why you can have a normal level. Now, let's also remember that these modality that we're doing here now, with these cases here, juicing every possible question out, is a very good thing for third-year medical students studying for their shelf exams. So you're on a rotation, you're on your medicine rotation, you're on your neuro rotation, you're on a family practice rotation, but you're on your core rotations, okay? And you're in your core rotations, and you're studying for your shelf exam, this is how to ace your shelf exam. You take a few diseases, you know them all the way, and help you bump it up. Help you bump it up. Plus, the point about these cases is it's not just the individual
This
case.
file has been copied
It
from
tells you and teaches you how to think about every disease.
www.feedyourbrain.com.
When you are studying from now on, you can be sure that your studying is going to go like these cases. Here's a case of B12 deficiency and macrocytic anemia. How do I extract every single question out? You're going to see it's going to have an effect on your studying. You'll study her deeper because you're going to think just like this. What is the most likely diagnosis? What is the best initial test? What is the most accurate test? So the peripheral smear is the best initial test because B12 level can be falsely normal. Bone marrow is never, I'm never doing a bone marrow first. How you doing? How you doing? How you doing? My name's Conrad. Bang! No. Schilling's test has been around, but it's never first. Do the peripheral smear, which will show an abnormality on that peripheral smear. It's available immediately, and it has greater sensitivity than a B12 level. Did you know that? A peripheral smear has more sensitivity than a B12 because a B12 level is falsely normal in 30%. Next case question. This question's fantastic because here we're going to look at the images of all of the smears. Oh, look at all these guys. Aren't they pretty? Look at all of them. Look at all these beautiful peripheral smears. 5 peripheral smears. Let's see. We have image A. And image A shows red cells, and image A, if you look close, shows cells that are shaped like that. Ooh, it's a teardrop. It's a teardrop. What you get from myelofibrosis? Because you're going to die. Teardrop. Because there's no cure. Teardrop cells. Because there's not really any really great therapy. Teardrop. Because it makes you feel wicked and tired and crappy. Teardrop. Teardrop cells, myelofibrosis. You get teardrop cells in myelofibrosis, image A, because the red cells, you ready? They're trying to get through the fibers. You know, it's like being born and you get caput. What happens to your head when you try and squeeze it through a tight area? They get squeezed into a plane. So what teardrops are, as the red cells squeeze through the fibers, teardrop cells are like caput for red cells. Oh. Myelofibrosis, pancytopenia, big spleen. Treatment, supportive, transfuse, and I bet you won't notice, treatment for myelofibrosis, lenalidomide and thalidomide, TNF inhibitors. Teardrops, myelofibrosis. Choice B shows helmet cells, fragmented cells, schistocytes, helmet cells, fragmented cells. It's also known as microangio, micro, small, angio, blood vessel, pathic, evil, bad small blood vessels, hemolytic anemia. Microangiopathic hemolytic anemia. So that is schistocytes and helmet cells. Is that found in B12? No. Schistocytes and helmet cells are found in all of our favorite 3-letter things. DIC, TTP, HUS. DIC, disseminated intravascular coagulation. Hemolytic uremic syndrome. Thrombotic thrombocytopenic purpura. DIC, TTP, HUS. Schistocytes and helmet cells. Fragmented cells. Also known as intravascular hemolysis. But there is no intravascular hemolysis associated with B12 deficiency. Now, choice C, those arrows. You see the arrows in the image? Look at the image. See the arrows? I think we're trying to point to something. Ooh, those images. Well, I think we have something like this. Ooh, tasty red cell. That's great. Tasty cell. Mr. Spleen, I like this cell. Tasty. Can I get some compliment on that, please? I hope you tasted better. Can I have a compliment? Yummy. Mr. Spleen, take a bite out of cell. Wow. Choice C shows bite cells, which is the spleen looks at the red cell. And the spleen, spleen's interested. I feel like I'm a cooking show. Next year I'm going to do this Conrad Fisher's cooking show. Cooking with Conrad, okay? And the spleen sees, you know what the spleen sees? The spleen sees a Heinz body. The spleen sees a Heinz body in those cells, right? And the spleen goes, oh my goodness, look at those. Look at that precipitated, oxidized hemoglobin in your membrane. That's so dirty, that's disgusting. Who dresses you? And the spleen goes, and takes a bite out of that. Okay? You're trying to think about taking a bite out of the paper, I know that. But it's not my taste. There's too much fiber in the diet for this. Too much fiber. Okay? It gets baldy stool. So I don't drink it eat it too much. So that's what happens. The spleen takes a bite out of those cells and pulls off. The bite cells take out the Heinz body. So the bite cells, the spleen, takes a bite out of the Heinz body. So the cell goes by, and the spleen sees this thing precipitated, and it takes a bite out of your hiney and makes a bite cell. Okay? Now, Heinz bodies happen with precipitated, oxidized hemoglobin in the red cell membrane. Now, bite cells are a part of G6PD deficiency, and they're not part of B12 deficiency. Remember, the spleen likes to clean up those cells, so it looks at it and goes, oh, this is disgusting. Who dresses you? Your mother? Let's fix that up. Sort of like Queer Eye for the straight cell. Now, choice D. Choice D is, look at that image, hypersegmented neutrophils. How many lobes do you normally have? You normally have, 3.5. 3.5 scale, degree of difficulty, it's like cliff diving. 3.5 lobes per, 3.5 lobes per neutrophil. Now, what's the difference between macrocytic and megaloblastic? Dun, 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 dun. Megaloblastic means hypersegmented neutrophils. Macrocytic just means a large size. Now, there's a lot of things cause macrocytic: alcohol, B12, folate, mercaptopurine, azathioprine, liver disease, hyperlipidemia, cellulite sticks on the side. But there's not that many things that cause hypersegmentation, which is megaloblastic. Choice D is the answer because it shows megaloblastic, which is hypersegmented neutrophils. Megaloblastic, hypersegmented neutrophils. Now, what does that make choice E? Choice E, where are we pointing at? Where's the central pallor? Wow. Now, instead of having the central pallor to those red cells should normally be in a biconcave disc. Ooh, biconcave disc. To me, everything looks like infinity. Well, what happens is that should normally produce a red cell that is pale on the center. Choice E shows a red cell with no central pallor. So therefore, it's a spherocyte. Do you know why it is that we have a biconcave disc? Red cells are normally a biconcave disc because they're more flexible. It's like a frisbee. Red cells are normally more flexible, like this, biconcave disc. However, the biconcave disc also has more surface area for oxygen delivery and picking up carbon dioxide and delivering oxygen. So a biconcave disc has more flexibility. But a biconcave disc is not a natural structure. What's the natural structure of the universe, says Aristotle? The spheres. Music of the spheres, right? For I have heard the mermaids singing, but I know they do not sing for me, says the love song of J. Alfred Prufrock. The natural shape in the universe is not a biconcave disc. That's not the natural shape. The natural shape, if you don't have ankyrin and spectrin, the natural shape in the world is a sphere. I'm going to squeeze this a lot, and I'm going to make you a diamond engagement ring. No, anyway, sphere. Okay. Now, choice E is a spherocyte. It's lost its central pale area. It's a red cell that has too much content and too tight a membrane. It's extra content, the membrane is so tight it's lost its natural shape and has become a sphere. It's wearing a too tight membrane. What are you doing? You're like a size 14 cell wearing a size 6 membrane. What are you doing wearing that too tight membrane? Makes it look rounder, you know? Spherocyte. So, the answer in this one is D, hypersegmented neutrophils. That means megaloblastic. Megaloblastic and hypersegmented mean the same thing. B12, folate. Next one. Now, we have in this person the same thing, except it's asking another question. Confirmatory diagnostic test. Now, what confirms somebody has B12 deficiency? Well, in this case, gee, you notice all the answers? They're all a little bit right, and that's our issue. All the wrong answers are going to be partially correct. Anti-intrinsic antibodies are found because that's the very essence of pernicious anemia. Antibodies against the parietal cell, antibodies against intrinsic factor as an autoimmune phenomena, and you get pernicious anemia. Bone marrow will be abnormal. Homocysteine goes up, but homocysteine is not specific to B12. It's up in B12 and in folate deficiency. Both give a homo. You get a homo in both. Homocysteine is up in both of them. Turns out that methylmalonic acid is elevated only in B12 deficiency. Because what does B12 do? It transfers methyl groups. Oh. Methylmalonic acid is extremely important when you got a story like B12. You got a story like B12, but an equivocal B12 level. You got a story like B12, but an equivocal B12 level. Story like B12, an equivocal B12 level. I got a macrocytic megaloblastic anemia. Macrocytic megaloblastic anemia, maybe got some neurological problems, and the B12 level, she's not sure. She's not sure. No estoy seguro. Methylmalonic acid. Methylmalonic acid. Story like B12 at a B12 level that's equivocal. Methylmalonic acid. Next one. Same person. What is most likely to be found? Now, we have the cases added to these questions because we want to make sure you understood that we are always talking about the same case. In other words, you get a B12 question. You could ask it most likely diagnosis. You could be asked what is the best initial test to smear. You could be asked what is the most accurate test, methylmalonic acid level. You could be asked what's the best initial therapy. In this case, we're simply saying what laboratory abnormalities might you find in a beautiful, beautiful multiple choice question. It's asking you to know that B12 looks a lot like hemolysis. High bilirubin and a high LDH. Looks a lot like hemolysis, a high bilirubin and a high LDH, except the reticulocyte count is low. Because the red cells are made, but they're destroyed as they leave the marrow. So the reticulocyte count is low. The red cells are made, but they're destroyed as they leave the marrow. So the reticulocyte count is low. And that's why the answer is here is answer D. Because the red cells are made, but they're destroyed as they leave the cell, as they leave the marrow. That's why the LDH and the bilirubin is high, but the reticulocyte count is low. Good question for B12. Now, next question. The patient presents with low reticulocyte count, high bilirubin, high LDH. Surprise, surprise. She has a peripheral neuropathy because you need B12 for normal neural development. Why do you get a high bilirubin? Because the red cells are destroyed in the marrow. There's no decreased biliary clearance. There's no defect with conjugation, Gilbert's syndrome and all those other horrible Roeder's syndrome and all those other syndromes I can't understand. Homocysteine has nothing to do with the bilirubin. Red cell obstruction in arteries and arterioles would be intravascular hemolysis. This is not intravascular. That would be DIC-TTP-HUS, DIC-TTP-HUS. P450 has nothing to do with this. The red cells are destroyed in the marrow before they leave the marrow. That's why the reticulocytes are low. If you did a bone marrow biopsy in this patient, what would you find? Normal cellular marrow? Hypercellular marrow? Hypocellular marrow? And the answer is hypercellular. But Conrad, I don't understand. How could there be a hypercellular marrow, but there's no reticulocytes? Because the cells are made, but they're destroyed just as they're leaving. What do you mean they're made, but they're destroyed? Yeah, it's kind of like, getting stuff from the store and you drop the bags on your way out the door. You went to the checkout market, you paid for everything, and then you dropped it just as you left the store. It's like going to the china shop or going to stores or buying glass, and then you paid for everything, it's in the bags, and just as you're leaving, bang, you smash it on the front door. And then you go back and buy some more. That's why the marrow is hypercellular. So you have all these fragments, but not intravascular fragments. You have the signs of the destruction of the cells, the high bilirubin and the high LDH. The store is doing a booming business because you keep going back and buying some more, but there's none out in the periphery. So that's what it's like. It's like buying glass, buying mirrors, and smashing them just after you left the checkout, before you left the marrow. So the marrow is hypercellular, but there's none in the periphery. Oh, that's bad, huh? Let's look at this next slide.
This file has been copied from www.feedyourbrain.com.
Let's go from the bottom up. Give us a little variety. Choice E. Choice E is a hairy cell, which is called a hairy cell for the very odd reason of it's hairy. We're going to get the cameraman to be able to get a GED from medical school, I'm sure. After 16 years of filming, when the first day I can get the camera guy to be able to pass the medical school exams and to be able to do well on step 2. Okay, my last camera guy in the step 3 exam matched into ophthalmology at Mayo Clinic. I'm telling you, just from watching these tapes and doing the recordings. It's fantastic. So hairy cell leukemia is choice E. You look for pancytopenia, middle-aged guy, big spleen. Pancytopenia, middle-aged guy, big spleen. You might be, hey man, that was the person you said for myelofibrosis. Myelofibrosis is older, and myelofibrosis has teardrops, not hairy cells. Choice D, look at that big mutant cell here. That is a smudge cell. Now, a smudge cell, in fact, is an artifact. A smudge cell is not a real cell. There's no cells that go around, red cells, white cells, platelets, and smudge, like a stepped-on jelly donut. That's what a smudge cell is. A smudge cell is a stepped-on jelly donut. I will now demonstrate with this jelly donut, that I brought for this purpose. And what ends up happening is, all the jelly inside, which is the nucleus, gets squished and squishes out to both sides. A smudge cell is because the lymphocyte in CLL, the nucleus is fragile. And the fragile nucleus breaks when the cover slip is pressed on it. And that's a smudge cell. It's a fragile fragile nucleus of a lymphocyte. It's an artifact of cellular development. Smudge cell. CLL. Smudge cell in CLL. It is an artifact. It's not what you expect for real inside. In other words, if you could go inside the cells, inside the bloodstream, and see what things are really looking like, there's nothing floating around with a smudge cell. Artifact. CLL. Choice C. See the little purple dots in the cells here? Well, those little purple dots, they're not normal either. They are the remnants of nuclear material. A little bit of chromatin, nuclear chromatin there as a residual that happens First of all, from splenectomy. They happen in splenectomy and occasionally in Crohn's disease. Those little purple dots, one of my favorite names, the Howell Jolly Body. Man, I like that. I'd go into hematology just to be able to go around talking about jolly bodies all day long. It's a jolly body. It's a Howell Jolly Body. It's the best part of the blood. I had my spleen taken out for Christmas. I know my name is Mud. I got little bits of chromatin stuck in my little red cell. And if you can't tell, I'm going to say you're going to fail and go to hell. Oh, it's a Howell Jolly Body. It's in splenectomy. Try and look at some blood smears, and they you will find see. It's a little bit of chromatin that's stuck inside the cell. And if you start to study medicine, someday you'll be able to tell. Okay? Howell Jolly Bodies. Makes me happy just to think about it. Splenectomy, Crohn's, little bits of dots. Okay. Can you get my beds refilled, please? I know what you're thinking, but just because I'm happy
This
about
file
what I
has been
do,
copied
just 'cause
from
I like looking at blood smears and like to think about all the
www.feedyourbrain.com.
accumulated knowledge of thousands of years of medicine, just because I like to think about all the accumulated nifty things that we can learn and do for people, doesn't make me weird. It makes you boring. Howell Jolly Body. Now, answer B is an acanthocyte. Acanthocyte. That means without canto. No. Acanthocyte means you get the spikes on your cells, that's all. And acanthocytes can happen from liver disease, and acanthocytes just happen as a response to various stressors in the marrow and in the periphery. And frankly, it doesn't mean very much. It just means spiky cells. Why don't we say spiky cells? I don't know. Acanthocytes, spiky cells, no big deal. You can't take a lot of meaning. Howell Jolly, splenectomy. Smudge, CLL. Hairy cell, middle-aged guy with pancytopenia and a big spleen. Acanthocyte, whatever. Choice A, we see on this smear macroovalocytes. Look, we've got macroovalocytes. Ovals and big. Look at that. Oh, look at those cells. Look at those big ovals. Okay, so the thing is, we got those big oval cells, and it's just an abnormality associated with B12 deficiency. It's a good question, and it's the fact. It's just the fact that the cells get abnormal shape. They're not just large, they're in abnormal shape. Okay? There's a different shape. I should say abnormal. Different shape. Next slide. Ooh, look at all these nifted images of tongue. Ready? Ooh, look at this, like the Rolling Stones slide. Gene Simmons. We should do that with celebrity tongues here. Choice A, big check. Choice B, Gene Simmons. Okay. So what do we see? Choice A. Ooh, why your tongue? It is so smooth, so fresh. Well, nobody really wants to have an overly smooth tongue. Okay, smooth tongue is actually bad. Okay, smooth tongue is bad because in reality, the reason you're able to taste things is because you have a bit of roughness to your tongue. And the roughness actually takes off particles of food, which you receive and experience the world as taste. That's why the metaphor for religious experience, and certainly in most of the New Testament stuff, many others, is taste. Why? What does an orange taste like? Tastes like an orange. But if your tongue can't take off parts of the chocolate or the food, you can't taste anything. So a smooth tongue is actually bad. If you had a smooth tongue, you won't eat as much. You're probably, it's not a competitive survival advantage. So you get a smooth tongue, glossitis and B12 deficiency. You lose the surface, and that's bad because you lose the taste. And therefore, you're not willing to survive as much. You don't eat as much. Now, choice B is just macroglossia. It's just a big tongue. Look at choice C. It's a fissured tongue. Fissured tongue? You're showing us your tongue, Dr. Fisher? No, fissured with two S's. Fissured. Okay? Tongue fissures, like in the lungs, major fissure, minor fissure, anal fissure, Conrad fissure. It's an abnormal variant. It doesn't mean anything. And choice D is a wonderful picture of thrush. It's basically candida infection of the back of your throat. It's perfect. And remember, the biggest difference in choice D, if you look at the picture of choice D, is that the thrush will scrape off and hairy leukoplakia will not scrape off. So choice D is thrush. It's candida. It's like vaginitis of the back of your mouth. And you treat it with clotrimazole as you would with the candidiasis of the vagina. And it scrapes off. Thrush, no big deal. The answer to this case is choice A, which is glossitis, smooth tongue. Now this actually in B12 can extend right down your GI tract, and it causes diarrhea because the food slides. It's sort of like being on a water slide. Like being on a water slide. Goes right through, slips right through. Just remember that the ability to be alive is based on taste. That's why people who have no salivary glands don't eat, because without the saliva, they don't absorb food particles. If you have a smooth tongue without a little roughness, we're never going to be able to taste anything. And you won't survive as much. Glossitis. Next question. Next question. Same lady. Decreased sensation in the feet. And it simply says, what is the most likely cause of this patient's disease? Now, is alcohol associated with B12 deficiency? No, in no way it's not. Macrocytic anemia, but not B12 deficiency, and not megaloblastic. Alcoholics get increased folate deficiency. Now, bacterial overgrowth, can that cause B12 deficiency? Yes. Now, this is a pretty much unusual disorder now, bacterial overgrowth, because we don't do gastric ulcer surgery. Back in the old days when we used to have the guts attached here and then we take half the stomach out and reattach part of the bowel, flopping around loose like that, you used to get bacterial overgrowth symptoms, Roux-en-Y, Bill Roth surgeries. But pretty much that's pretty old-fashioned stuff, because ever since we had proton pump inhibitors, there's not that much bacterial overgrowth anymore. Dietary insufficiency, it could be. But it's really hard to be deficient in B12. You have to be a total vegetarian, a vegan, and not eat any B12 for a long time, and have bad luck and be a bit dumb, because most of the vegans know that you can get it by having a little yogurt or take it by replacement. Gastrectomy can cause B12 deficiency. Did you know what you need in the stomach that's indispensable? You could be on proton pump inhibitors for your entire life, so you don't need the acid. The acid activates the pepsinogen, the pepsin. The pepsin eats the protein. But you don't need the protein that's digested in the stomach, so you don't need the pepsin. You need the protein that's in the small bowel. You need trypsin, chymotrypsin, proelastase, carboxypeptidase. But you don't need what's in the stomach, not the digestion. You don't need pepsin. If you don't need pepsin, you don't need acid. The stomach, what's there? Well, if you don't have acid, you don't need the mucus. If you don't have the mucus, you don't need the prostaglandins. You don't have to have the prostaglandins. You don't have to have the mucus. You don't have to have the acid. You don't have to have the pepsin. You know the only thing that's indispensable for life, necessary for life, in the whole stomach, is intrinsic factor. And although you take the word intrinsic as to mean something like innate, within, permeating, intrinsic, indispensable, or innate feature. The actual word intrinsic means indispensable for life. The only thing indispensable for life in the stomach is intrinsic factor, whose name means necessary for life. Because without intrinsic factor, it's deadly. You get pernicious anemia, which is deadly. You know what the word pernicious means? Deadly. Cute, right? I'm telling you, we're going to get this cameraman his GED for medical school, because he walks in and he goes, right, without something that's necessary for life, it's deadly. So, Mike, what'd you learn on the film shoot today? I learned that without things that are necessary for life, you die. Send in your tuition check today. But that's it. The only thing in the stomach that's necessary for life is intrinsic factor. Weird, huh? You used to think you needed the acid. You don't. Weird. So, the only thing in the stomach necessary for life is intrinsic factor, and that's why pernicious anemia kills you. Look, you see pernicious anemia, as a thing to get test questions on for step 2, which gives you hypersegmented neutrophils, where you have to do Schilling's tests 40 years ago, where you get a bunch of blood tests and smears like ovaldocytes and hypersegmented neutrophils. You can get a smooth tongue, you can get peripheral neuropathy and other neurological problems. But you know, 50 and 60 years ago, if you had pernicious anemia, you were a dead duck, man. You got neurological problems and you got anemia with a hematocrit of 10 and you died of anemia. Died of anemia. So why don't we think about that? Pernicious anemia for you is a source of test questions that you treat and cure in 5 minutes. But pernicious anemia was a 100% fatal disorder not too long ago. So could we just feel a little grateful for a second that the most common cause of B12 deficiency is pernicious anemia, and you have the power to cure it and treat it in your hands in 5 minutes. And you can save a life. Wow, look at that. Now this next question, the same patient, and the difference is that it tells you that there's a high methylmalonic acid and increased homocysteine. Now remember, high methylmalonic acid is specific to B12. Homocysteine is not. Homocysteine could be in folic acid as well. What should you do to confirm the etiology? Well, this question is asking you, do you understand that B12 level, smear, and MMA, methylmalonic acid, diagnose B12 deficiency? But they don't tell you the etiology. The etiology is determined with anti-intrinsic factor and anti-parietal cell antibodies, with intrinsic factor and parietal cell antibodies. Bone marrow will show a hypercellular marrow, but a lot of things can show hypercellular marrow, not specific. D-xylose testing is a test to see if the bowel wall is intact. If you have a person who's got celiac disease and has fat malabsorption, use D-xylose sometimes to tell you if the bowel wall is intact. It's kind of an old test anyway. So D-xylose is for bowel wall being intact. Schilling's test is a choice of most common wrong answer in B12 questions, because Schilling's test is an archaeologic test to tell the etiology of B12 deficiency and should not generally be used. Small bowel biopsy is the most accurate test for celiac disease, Whipple's disease, tropical sprue. Tropical sprue, bacteria in there. Whipple's disease, bacteria in there. Celiac disease, flattened villi. Now, celiac disease, tropical sprue, they can give you B12 deficiency by showing you the abnormalities that affect the terminal ileum. But the test that you're going to use to tell whether it's pernicious anemia, anti-intrinsic factor and anti-parietal cell antibodies. This last question asks you if you understand that B12 replacement can result in hypokalemia, period. And there are a lot of things that when red cells are destroyed, when myocytes are destroyed, tumor lysis, rhabdomyolysis, hemolysis, when cells are destroyed, they release potassium. And the cell destruction releasing potassium is very clear. But cell production resulting in hypokalemia is rare. It's very hard for cells to be made so rapidly as to use up all the potassium. But that is the case in a person who has B12 replacement. Because you start to make all these red cells, white cells, platelets so quickly, it uses up all the potassium you have. And you can actually have a dangerous hypokalemia and replace for it. Replacing B12 doesn't give you anything to do with the acid-base status. It doesn't change phosphate that much. Phosphate can happen when you make myocytes, but not when you make the red cells. So this question here is simply asking, when you're replacing B12 or folate and you have a severe pancytopenia, you must watch out for hypokalemia, and that's it. Another question is, what is the most common of all the neurological abnormalities in B12 deficiency? The most common wrong answer typically is subacute combined degeneration of the cord. Subacute combined degeneration of the cord with loss of the position and vibratory sense is unusual. It is more common to lose sensation. It's more common to just not feel as much than it is for you to lose the position of your vibrator like that. So, Their subacute combined degeneration of the cord is relatively uncommon. Numbness and tingling is the most common. Dementia and psychiatric disturbance are even less common than subacute combined degeneration. Now, are these abnormalities reversible? And the answer is yes, they are, if they're there for a short period of time. Now, someone who just had a little tingle, a little numbness, a little abnormal sensation can be fixed. Somebody's there demented like this for years is not going to be reversed. Now let's summarize this case. B12
This file
deficiency,
has been copied from www.feedyourbrain.com.
but megaloblastic hypersegmented neutrophils. The best initial test is a smear. Methylmalonic acid is when there's a story like B12 and equivocal B12 level. B12 levels can be normal in 30% of people who have a deficiency because the carrier protein, transcobalamin, is an acute phase reactant. White count, sed rate, C-reactive protein, ferritin, and transcobalamin. Now, the most common neurological abnormality is peripheral. The least common is dementia. It can be reversible if it's there in short duration. Now, Schilling's test is rarely necessary. If you have B12 deficiency and you want to confirm the etiology, pernicious anemia is the most common, and you do it with anti-intrinsic factor and antiparietal cell antibodies. You can't replace B12 orally because it won't be absorbed. If you fix the B12 disease and then you give it to people orally in massive doses, you may have some effect. But generally, pernicious anemia must be replaced intramuscularly for long-term administration. Pernicious anemia is an autoimmune problem. Happens when people get older, along with vitiligo, which is a common abnormality. When you replace B12, you can get a hypokalemia, which can be, in fact, quite dangerous. You get a smooth tongue and a smooth bowel, which in fact can lead to other food malabsorption. The bone marrow will be hypercellular, but the cells are not released. They're destroyed as they leave the body, as they leave the marrow. That's why you have a low reticulocyte count, but a high bilirubin and a high LDH. In addition to macroovalocytes and hypersegmented neutrophils, you get abnormal shapes, but bite cells, Heinz bodies, are inside other diseases. The main thing for you to know in terms of B12 deficiency has to do with the fact that you know to do a peripheral smear first, that Schilling's test does not diagnose B12 deficiency. It doesn't determine an etiology, even if you did occasionally do it. You're going to like B12 as a question because it's easy for you to master. If you're a third-year medical student practicing for your shelf exam right now, I guarantee you that by the end of this investment of time, you will know as much or more than any resident or attending you deal with on the floors. And that's the end.